Okay, so this is going to be the start of Unit 6. We're going to talk about vision and hearing. We're going to start with vision. We're going to talk about a few things. We're going to talk about different screening tests, cataracts, glaucoma, which is open angle and angle closure glaucoma, retinal detachment, age-related macular degeneration, and diabetic retinopathy. This is a good picture that just talks about the anatomy of the eye. You do need to know what the steps would be from the person seeing a picture, going through the pupil back to the optic nerve. So just make sure that you do review your anatomy as far as the eye goes. A couple of things that I will point out here. So you have your anterior cavity, which includes the anterior chamber and posterior chamber of the eye. The anterior chamber, which is starred, is filled with aqueous humor. It's the space between the cornea and the iris. And then the posterior chamber, which is starred, is also the space between the iris and the lens, which the lens has a star as well. The canal of Schlemm, this is located at the junction of the sclera and the cornea, and it allows for aqueous humor to flow between the anterior and posterior chambers. This will become important when we talk about closure glaucoma. The posterior cavity of the eye, this is everything behind the lens. It contains vitreous body, which shapes and supports the eye. The lens is involved with cataracts. The optic nerve is involved with glaucoma. And the retina itself is involved with retinal detachment, as well as diabetic retinopathy. Moving on to screening tests. So visual acuity, I do want you to review what 20/20 means, what OD, OS, and OU mean. Snellen's chart, this assesses distance visual acuity. You place the chart 20 feet from the individual, and the vision is checked with right eye, left eye, and then both eyes. What does it mean if a person has 20/40 vision? Okay, so this is going back to previous learning as far as how visual acuity works. So what it means is that a person with 20/20 vision could stand 40 feet away and read what a person with 20/40 vision can read at only 20 feet. So if the number is higher, that means that your vision is poorer, okay? If you have 20/20 vision, it's good. If you have 20/40 vision, that means that you cannot see as well as a person with 20/20 vision can see. Then looking at Jaeger's, this is actually assessing near vision. It's mainly assessed in clients over 40 years old. And what they do is they hold a handheld chart about 14 to 16 inches from the eye. And clients with decreased accommodation will need to move it further away to see it. So the best example I have of this is when you think of maybe your parents or grandparents, and when they're trying to look at their phone, they have to hold it farther away. Their arm isn't long enough for them to actually see it well. So that is the same kind of test that Jaeger's would be. Whereas Snellen's is going to be your chart with the big E and all the letters, and you read as far down as you can on that to see when they're at. Tonometry, this is a test that measures the intraocular pressure. Color screening is screens that are for color blindness. Penlight, you guys should know, we use this to assess pupils and the reaction to light. And an ophthalmoscope. This is used to actually view the posterior chamber of the eye. Usually they do need to dilate the pupil in order to see the optic nerve, the macula, and the retina. Looking at cataracts, you can see up in the corner, I did include the page number from your Burke book that talks about cataracts. This is just a basic understanding for you guys. You do need to go in the book and actually read more about this. Cataracts itself is the clouding of the lens of the eye that ends up impairing vision. There's multiple risk factors, including exposure to sunlight, cigarette smoking, heavy alcohol consumption, congenital conditions, eye trauma, diabetes, and certain medications. It's normally caused by aging, but again, can be caused by other things. Usually affects both eyes, but tend to develop at different rates. With cataracts, both near and distance vision are affected. Your pupil will appear to be cloudy gray or white rather than black, and that's because of the discoloration of the lens. Okay, it's seen with an ophthalmoscope exam. Your red reflex is lost. So what this is when they shine a light in the eye, You normally can see a reddish orange glow in the pupil when that beam of light is directed into it. These patients that have cataracts are not going to have that. And it's going to be treated with surgical removal and intraocular lens implants. As far as manifestations go, again, decreased near and distance visual acuity. That means they have difficulty reading small print and seeing road signs. Okay. They're going to have problems with glare, so from sunlight or headlights of cars at night. They're going to have changes in their depth perception, so they might have difficulty stepping off of curbs, walking down stairs, or judging distances. And they're going to have changes in color perception, so the brightness of colors is going to dull over time. This is a good picture to kind of show you what the difference is between normal vision and vision with a cataract. So as you can see, it's pretty blurred. The colors just aren't as sharp, and they're going to have difficulty with that visual acuity. As far as management, again, we're going to do surgical removal of the opaque lens and implantation of an intraocular lens. So usually it's a surgical, really small incision in the cornea, and then they use something called phacoemulsification. And what this does is it basically breaks up the cataract into small pieces and then vacuums that cataract out, or the lens out. And then they end up putting in an implant, which is an intraocular lens. It usually is delayed until the cataracts actually interfere with the patient's ADLs or enjoyment of life. It's an outpatient procedure. They're normally discharged within 2 hours post-op. They do need to wear an eye patch at night and keep their eyes protected by sunglasses outside for the first 1 to 2 weeks post-op. Keep in mind that this says eye patch at night. They do not need to wear an eye patch 24 hours for the first 1 to 2 weeks post-op. It's just to protect them at night so that they're not scratching or having any issues with that lens implant. You can position them in semi-fowlers or on their non-operative side, and there will be no bending, stooping, etc. afterwards. Keep in mind when I say on non-operative side, when they correct cataracts, if it is happening bilaterally, they will still only correct one eye at a time. This is done because if there were to be something wrong, we're not messing with their vision on both sides. They're still going to have one good eye until the other one heals, and then they can go in and get their other side done. Okay. With this is going to be something that you'll notice that afterwards they're going to have much more clear vision. And then they're also going to notice that colors are a lot brighter. Some of them don't even notice because of how gradual it is, how much the dullness of colors affects them until they get this done, and then they can actually see afterwards. This is a video that I had posted. It's obviously going to be hard to watch because it's not working on here right now. It's basically just a video that shows you how the cataract process works and how the phacoemulsification gets rid of this lens, and then how the implant goes in. I will try to find another video and post that to the Canvas page if I'm able to. But basically, if you just YouTube cataract surgery, you'll see multiple examples on there. When it comes to client education, you need to include the family, both with written and verbal post-op instructions. You need to demonstrate how to correctly instill eye drops. Most of these patients are going to be prescribed an anti-inflammatory such as prednisolone and a prophylactic antibiotic such as Ocuflox for drops afterwards. And compliance is crucial. Again, this is dealing with their vision. They need to make sure that they understand not only how to install the eye drops, but also how often they need to be instilling them and how often they'll be on them until the next surgery or until after they fully recover. This is why it's important to include the family in teaching. A lot of times these patients don't get put to sleep for this procedure. They have to be awake, but they will receive something such as like Versed that might make them kind of sleepy and not remember things. So that's why family is so important in this teaching. You need to avoid any activity that can raise their intraocular pressure, such as lifting heavy objects, straining with bowel movements, sneezing, coughing, vomiting, etc. It usually could take 4 to 6 weeks before their best visual acuity is achieved, but could take up to 3 months. And if they have any of the following postoperatively, they need to make sure that they're reporting that, such as eye pain, worsening of vision, nausea, vomiting, or itching and redness. Moving on, we're going to talk about glaucoma. This is a disease that's characterized by increased intraocular pressure and gradual loss of vision. So the normal intraocular pressure is 10 to 20 milligrams of mercury. Again, this is going to be increased from that. It's a silent thief of vision. Peripheral vision is lost so slowly that it's often not noticed until late in the disease. And it's the leading cause of blindness worldwide. There are two types, and we'll discuss both of them. There's open angle glaucoma and angle closure glaucoma. What I want you to take from this is that angle closure glaucoma is more likely to be an emergent situation, whereas open angle glaucoma is what leads to the loss in vision. Going back to the picture, you can see in the glaucoma picture that their peripheral vision is what's being affected. Okay. Both eyes are usually affected with this. If untreated, it will eventually lead to blindness. Excuse me. And their manifestations are going to be painless, gradual loss of peripheral vision, difficulty adapting from light to dark, blurred vision, halos around lights, difficulty focusing on near objects. And then when we look at angle closure glaucoma, or closed angle glaucoma, this is when the angle between the cornea and the irises closes completely, which blocks off that drainage of aqueous humor from the eye. This leads to an abrupt increase in their intraocular pressure. Because of this abrupt increase, it damages the retina and the optic nerve. In acute angle closure glaucoma, it usually affects one eye, and it occurs suddenly. As I said previously, this is an ocular emergency, and it requires immediate intervention. Without prompt treatment, that affected eye will go blind. So normally what happens is the episodes occur when the pupil dilates, and that's what closes the angle between the cornea and the iris. Because of this, we need to make sure that these patients avoid any medications which may dilate the pupil. And manifestations are going to be unilateral, abrupt onset of eye pain and headache, nausea, vomiting, blurred vision with halos around the lights. Affected eye is going to be red and their cornea may be clouded. And they're going to have a dilated and fixed pupil, meaning their pupil is not going to be reactive to light. This is a good picture that shows you the difference between the two. You can see where that clogged drainage hole is in open angle glaucoma, whereas in closed angle, you can see that it's completely closed above that, meaning that there's no way for that drainage to happen. For diagnostic tests, we're going to look at tonometry, which again measures the intraocular pressure because that's going to be increased with this process. Visual field testing, this is going to identify their loss of peripheral vision. Normally it's performed at least once a year in patients that are diagnosed with glaucoma. That way they can closely monitor if they have any loss of peripheral vision. And optic nerve studies. This displays circulation of the optic nerve. And as glaucoma progresses, it's going to become pale due to the damage. Medications. This is where you're going to want to focus because this will be some tested material. So miotics, these increase the flow of aqueous humor and constrict the pupil. Okay. Obviously, each of these I did put some examples below, so you will want to know some of those names. Prostaglandins increase the flow of aqueous humor. These do not affect the pupil diameter, but actually dilate that meshwork in the anterior chambers and the Schlemm canal. They will change the pigmentation of the iris, so this will cause a change in the color of the eye of a patient. Prostaglandin. Anything that ends with prost, you can see that all of them end in prost. These are going to change the eye color for the patient, so you should make sure that you're educating them on that. Alpha blockers are going to dilate blood vessels in the eye, decrease production of and increase drainage of aqueous humor. These end in dine. You'll see that is the same on all these. And they will have a mild effect on the cardiovascular and respiratory system with them being alpha blockers. Beta blockers, you can see even for the eye drops, are going to end in OLOL, similar to beta blockers we use for cardiac conditions. These will decrease the production of the intraocular fluid. It can be absorbed systemically, which could lead to constriction of the bronchi, slow the heart rate, and cause hypotension. So if you think of beta blockers and you know their cardiac function, if these eye drops get absorbed systemically, they can do the same kind of effect, okay? Carbonic anhydrase inhibitors, these decrease the intraocular pressure by reducing production of intraocular fluid. Diamox is the one you're going to hear about most often for that. And osmotic diuretics, so these are used to decrease the amount of aqueous humor rapidly. Mannitol is probably the one you'll hear most often. You'll also remember this from any kind of increased intracranial pressure. Mannitol is going to be an osmotic diuretic that is given IV to rapidly decrease this amount. This is going to be a medication you're going to often see in those with angle closure glaucoma. And surgical intervention. As far as angle closure glaucoma, a laser iridotomy. This laser makes multiple small perforations in the iris, allowing the aqueous humor to drain from the posterior chamber into the canal of Schlemm. And then open angle glaucoma, a laser trabeculoplasty, sorry. Laser is used to open drainage into the canal of Schlemm by burning holes into that trabecular meshwork. And then they can also do a trabeculectomy, which is a permanent fistula used to drain aqueous humor from the anterior chamber of the eye. Moving on to age-related macular degeneration. It's a common cause of impaired vision and blindness in adults over 65. So age-related over 65. In this case, neurons of the macula, which is the area of central vision, can atrophy and separate from the cricord. Risk factors with this, again, advanced age, female gender, smoking, and family history. Their central vision becomes blurred and distorted. Peripheral vision remains intact, okay? So AMD is going to differ from glaucoma because the peripheral vision is intact and the central vision is affected. Straight lines can appear wavy or distorted. This is why we use an Amsler grid for diagnosis, which I'll show you on the next slide. They can use laser treatment or photodynamic therapy, which can slow the progression of AMD. These patients are going to use large print books and magazines. They may use a magnifying glass or high-intensity lighting in order to see central vision correctly. Early treatment can preserve vision and slow the disease. So as far as AMD goes, this is a good picture that shows you how they see their central vision. They lose that central vision, but their peripheral vision is fine. And then looking at an Amsler grid, it just looks like grid line paper. But a person that actually has AMD is going to see these squiggly lines, and they're going to have that darkened area in their central vision. Diabetic retinopathy. This is a disorder affecting the capillaries of the retina. The capillaries are no longer able to transport blood and oxygen to the retina and is the leading cause of new blindness in people ages 20 to 74. The pathophysiology is mentioned here. The biggest thing that you should know is that those capillaries end up having small hemorrhages into the retina. Eventually, this area becomes ischemic or dies, and then they can lead to having issues such as a detached retina. Yearly eye examinations are recommended for anyone with diabetes. This is a big part of education. They should promptly report any changes in vision. They should control their blood glucose very closely, and they should control their blood pressure very closely. In patients that end up with diabetic retinopathy, they can do treatment with lasers to slow the progress. However, it is not a cure. And as you can see, this is just a severe case of diabetic retinopathy where they have all of these areas of vision that they can't see, and their vision they do have is blurred because of that issue with the retina. Now moving on to the hearing portion, we're going to talk about screening tests, different types of hearing loss, otitis media, and Meniere's disease. This is, again, just a basic picture of the anatomy of the ear, something that you need to review on your own, especially in your health assessment book. Looking at screening tests, so otoscopic exam, this is when a trained personnel will visualize the inside of the ear using an otoscope. The Weber test, this test is used for unilateral deafness. They'll take a tuning fork and they make it vibrate and they hold it against the midline of the top of the head. In someone that does not have deafness, you will hear the sound equally in both ears. However, a person that has deafness will say that they hear it in one ear and not the other. The Rinne test, this is used with the tuning fork as well, and it compares bone conduction with air conduction. So they vibrate the fork and then they hold it on the stem on the mastoid process behind the ear. And when it's no longer heard by the individual, they tell you, and it's moved in front of the ear canal. Normally, they should be able to hear it in front of the ear better than they can when it's on the bone. If they move it to the front of the ear and they can no longer hear it, that means that they've had issues with hearing and issues with the air conduction. A whisper test, this is when the person performing the test will stand about 4 feet away from the individual without looking directly at them. So normally when this is performed, the person will stand behind the patient. They'll whisper a question and the individual should be able to respond appropriately if they were able to hear them whisper. And then autometric, this is when they go into a soundproof box. A series of tones are played at certain frequencies, and then they'll play them to each ear by both bone and air conduction to test their hearing. Moving on to hearing loss, there's 2 different types of hearing loss. There's conductive hearing loss and then sensorineural hearing loss. So with conductive hearing loss, anything that affects sound transmission from the external opening of the ear to the inner ear. This can be from obstruction of the ear canal, impacted cerumen or earwax. This is the most common cause, but there can be other causes, including a perforated eardrum or tympanic membrane, damage to the ossicles of the middle ear, or fluid scarring and tumors of the middle ear. Patients with conductive hearing loss are going to benefit from sound amplification by a hearing aid. That's a big thing to know, is that conductive hearing loss can be helped by using a hearing aid. Whereas if you look at sensorineural hearing loss, these are disorders that affect the inner ear or the auditory pathways of the brain. So this is causes of sensorineural hearing loss. Trauma, infection, diseases such as Meniere's disease, ototoxic medications, prenatal exposure to rubella. Noise exposure is the major cause in the United States. Some ototoxic drugs that commonly can lead to sensorineural hearing loss are aspirin, furosemide or Lasix, vancomycin, streptomycin, anti-malarial drugs, and chemotherapy. This affects the ability for them to hear high frequency sounds, meaning that hearing aids may not be able to help with this. So again, it affects the ability to hear high frequency sounds, so hearing aids may not help this, just because hearing aids could make the speech and background noise louder, which means that they won't be able to actually hear what they need to hear with the high frequency sounds. And then presbycusis, is progressive hearing loss that occurs with aging. Occurs due to the hair cells of the cochlea degenerating. It is a type of sensorineural hearing loss. It's very gradual. And then in this case, hearing aids and other amplification devices are useful. Because of it being the conduction due to the hair cells, it's a little different than if you're looking at just normal sensorineural hearing loss. So again, this type it will help, other types it will not. This is basically just the hearing loss that affects people because of aging. Otitis media is inflammation or infection of the middle ear or an ear infection, the most common middle ear disorder that affects people. It often affects infants and young children, but obviously it can happen in adults as well. Some risk factors are previous upper respiratory infection or any kind of eustachian tube dysfunction. There's 2 types. There's serous otitis media, which usually occurs when the eustachian tube is obstructed for a long time. and the negative pressure in the middle ear draws serous fluid from the capillaries. They're going to have decreased hearing. They might have a popping or snapping sensation in the ear. They may develop acute pain, bleeding into the middle ear, and rupture of the eardrum or tympanic membrane. And then acute otitis media, this is what you're going to think of more when you think of the young kids that end up having multiple ear infections. This usually follows an upper respiratory infection. Mucus and serous fluid collect in the middle ear, and that lack of drainage leads to infection with pus in the middle ear. It often causes severe pain in the affected ear, fever, hearing loss, dizziness, vertigo, and tinnitus or ringing in the ear. It's treated with antibiotic therapy, and it could also be surgically corrected with myringotomy and tympanostomy tube placement, or MNT is what you'll hear it as more often. So this is when a little kid goes in for ear tubes. This is what that surgery is actually called. So what it does is those tubes actually go in and just help with the drainage so that they have decreased risk of infection in that middle ear. In this picture, this side where it is nice and pale and normal, that is what it should look like on an otoscopic exam when they're looking at the tympanic membrane or the eardrum. And then this reddened area, this is going to be a patient that has otitis media. This is going to be that infection and those signs that they'll see. And on this page, this is what it will look like when they actually have a tube placement. So again, the ear tubes that they put in. This picture with it on the finger, that just shows you how small these tubes actually are. But when you're doing an otoscopic exam, it actually looks much, much larger, and it will be very obvious in that tympanic membrane so that they can see that the tubes are still in place. Eventually, those tubes will push out and fall out on their own, which is why they'll do otoscopic exams to make sure that they can visualize if that tube is still there or not. Moving on to Meniere's disease. This is a chronic inner ear disorder. It's caused by excess fluid and pressure in the labyrinth of the inner ear. It can be gradual or sudden onset. They will have recurring attacks of vertigo with tinnitus and gradual hearing loss. The hearing loss usually is unilateral, but it could be bilateral. They have severe attacks of vertigo that occur abruptly and are unpredictable, and they can last from minutes to hours. Treatment in this case is going to be aimed at helping the symptoms. Medications you're going to hear of most often for the vertigo and nausea are going to be meclizine, compazine, and Vistaril. Meclizine probably being the one you'll hear of most often. They need to maintain their fluid and electrolyte balance. They should have bed rest in a quiet, darkened room with minimal sensory stimulation. They can do a low sodium diet to help reduce the frequency of their attacks. They should avoid alcohol and tobacco, which can precipitate an attack. And they can also have an option of surgical changes. So this would be relieving excess pressure in the middle ear and or to block transmission of stimuli related to the balance and vertigo. However, with this surgery, it's a risk that they could have permanent hearing loss. So most of the time, people will try to just go ahead and take meclizine and be okay with this. However, if it's bad enough, some of them may decide to do surgery as an option. And that's everything we have on here. Just so you know, we are going to try to get as much of this part as we can done in class for an in-class lecture, but we just recorded this for you to have for extra. This will obviously be a big part of Unit 6, so just keep in mind that you always can come back to this and listen to it. Otherwise, good luck on your quiz and your exam.